Hey, everybody, it's Kevin and Donna, and welcome to another episode of the Med List. So, Donna, how was your Mother's Day? I hope it was beautiful and wonderful, just like you are as a human being.
Oh,
Are you
thank you.
spoiled?
You know what I was spoiled with? Time. Just time with my kids. I got a nice visit from my son and his girlfriend for a while and just got some great time chatting away and then a great FaceTime with my daughter and chatted for quite some time with her. So that's what I got and I loved it. How
Nice.
about you? How about Savannah?
I got to celebrate my beautiful wife and got to talk to my mama, and so those things were all taken care of on Mother's Day. I feel like it's just always so easy to, once you think about it for a second, realize how impactful mothers are in your lives. So
Mhm,
very thankful for all you moms out there watching. I know I have
mhm.
lots of folks that ping us on occasion that may or may not be moms, and we appreciate all of you guys in your comments and are very thankful for you. But for this episode, we're going to get into some other things that I'm very thankful for because I didn't know about many of them before, Donna. And
Yeah,
I'm going to hit our reel and we'll jump in.
sounds great.
So when you think of a chaplain, Donna, like looking at this episode and trying to get into the minds of the viewers kind of tuning in, especially the word clinical, like clinical and chaplain to me were those didn't compute. I thought, what is a clinical chaplain? That is
Yeah.
an interesting combination. But talking to Joelle kind of before we jumped on, now it makes so much more sense. Like there are so many dots to be tied together from all those sides and aspects, especially on the social work components and psychiatric elements, that I'm
Yeah,
super excited to talk to her.
absolutely. Me too. And I think it's great because what do we do at the Medlist? We bring people together and we educate people. And that's what we're doing here. And just so happy to have with us Reverend Joelle Johns. So thank you for being with us, Reverend Joelle Johns. And I want to introduce you and share a little bit of your background. So Joelle is a board certified clinical chaplain, death doula, integrative thanatologist, and psychospiritual counselor. She specializes in grief and grieving care. She has her master's degree in interfaith divinity and holds an additional certification, grief counseling. She is also a board certified spiritual care counselor. Joelle has background in community outreach and engagement advocacy. I loved when I talked to you once and saw something, you're fierce patient advocate, and I believe that of you. So thank you for your work in that area. Psychiatric social work, case management, geriatric social worker, which near and dear to my heart, with being certified geriatric pharmacist, but also she counsels one-to-one and also group counseling. And you've been active in social service since 1994 and end of life work since 2009. So thank you so much for joining us.
Thanks for having me. I'm thrilled to be here.
Yeah, and we just have so much to learn from you. So I would love just to touch on a couple of things that could you just tell us a little bit more about a clinical chaplain and also a thanatologist? Because I don't think those are words we throw around a lot. So if you could just share a little bit more about what those actually mean and how you might integrate with us as either being pharmacists or some kind of medical team and the patient and the family.
Oh, okay. The clinical chaplain piece, for chaplains to become board certified, they have to go through 4 units of what's called clinical pastoral education, which is sort of a unique training methodology. And the school that I used and went to for my training is a clinical chaplaincy training, and they lean into theory and psych theories and different types of therapy and interventions. So we have to put in 1,600 hours total across those 4 units of supervision and actual hands-on in the community or in the space that we want to focus on. So we spend time there. So once I got board certified, and I will tell you, it took me almost 3 years to get through that process after my degree. So it's intense. And And then the thanatology piece, I started back, gosh, I think it was 2011. There's a little school here in Massachusetts called Mount Ida.
Mm-hmm.
And I think it's been taken over by somebody else, another school. I think it's sort of glommed together. But they had a certificate in thanatology. So I took all those classes, and this was early online where it was almost like correspondence-esque, but there were some like learning platforms. So it was really cool. And then I have gone on to get additional certification in thanatology, which is the study of death and dying and grief and grieving. So like sort of like the whole scope of like end of life and post-death.
Mm-hmm.
Wow. So you got to tell me a little bit more. I mean, one, the 1,600 hours, amazing, like of that kind of dedication to it. Joelle, tell me, why did you get into it in the first place? Like what ended up pulling you into this career track? Because it's rather unique from the discipline standpoint and from the time commitment it would take.
That's a great question. And just for starters, my mom was a psychiatric nurse, and she was an only child. And I remember very distinctly the death of my Nana, her mom, because my mom had to make all these decisions by herself. And I remember the day that my mom refused to put my Nana on a vent because the doctor on call was like, we'll put her on a vent. And my mother said, is that going to make her get up and walk out of here? And is that going to change the trajectory? And it wasn't. So she said, no, you will not. And that was like my first like core memory of comfort care, if that makes sense, of comfort over invasive stuff it's going to cause more harm than good. So that's like that's always sort of in me. But then I was just sort of drawn to and could be very comfortable in end of life spaces throughout my life. And then I remember when I was looking for something to do with sort of extra time, because I really like to be in the community, I volunteered for hospice for the first time. And I sat vigil, and that was amazing. It was volunteers would sit so that people don't die alone. And part of the volunteer training, there's this like all different disciplines come in and they talk to you, the new volunteers, about like what they do. And there's this teeny tiny chaplain who's about 4'11", maybe. Her name is Carol, Reverend Carol. We're still friends to this day, but her way of doing chaplaincy was so cool to me. I was like, that's what I want to do. That's what I want to do. And this was back in 2009, and nothing was going to stand in my way. That was going to make that happen somehow. It took me a while, but
you got to tell us what was it that Carol did? What was it that just made you go, that's something special that I want in my life?
The story she told, because I always thought chaplains were, you sit with people and you pray.
Yeah, sure.
And that's not really my jam. But I have respect for it, or I wouldn't be doing what I'm doing. But I like to know like what the spiritual machinations are inside people, like what motivates them, what are they trying to unpack at this point in their life, like what needs to be resolved or examined or forgiven. And she was really good at it. She told this one story about somebody who she brought a beer to because that's what the woman had asked for. And like, that was her Eucharist. You know what I mean? That was, and they sat together and talked about hard stuff. And I was like, I love that. I love everything about that.
Mm-hmm.
Wow.
That honesty, that rawness.
Yeah.
You know, so I followed her around and I watched her do what she did. I probably drove her nuts at the time, but I watched her do her magic, and did she pray with people? Of course. But that wasn't her leading foot. And that's when I realized that there's a lot more to this than I knew.
Wow. The next one I had, Donna, and then I'll pass it off to you, is really this. So leading us down this road of really analyzing someone's kind of spiritual needs or just general needs at that time, especially such a difficult time. What was the tactic and the way that you guys would help unpeel a very difficult process? I mean, I think for the audience to know where I'm going with this one is this. we're so complex, right? I mean, as individuals, we have all of these components of our lives that are kind of siloed in general. And then we hit some points in our lives where they all kind of come together and we kind of recognize that we have all of these things going on. How do you start to unpack those, Joelle? And how do you start to unpack those so it is fruitful for the individual you're working with?
A lot of stuff comes from sort of almost like a surfacey start to, I start a little bit of life review.
Okay.
And when someone starts to tell you parts of their life, you really pay attention, like active listening. How you have to be totally focused. But you start to hear themes.
Okay.
You start to hear what people choose to talk about first. You know what I mean? What their priority is as they are there in that space in time. And you can start by asking about that priority. And you never want to like lead somebody or tell them how they're feeling. But I can observe that seems to be really important to you. Can you tell me some more about that? Do you know what I mean? And then it's like you just slowly start to, and it's you stay curious. And I never think that I know what someone's going to say, because people surprise me all the time. And if I think I know what they're going to say, then I'm not doing my job right, because then I'm putting my stuff on them, and that's not the work I'm doing.
Wow. I hope any clinician listening really listened to that. I think that's beautiful in so many ways. It goes even beyond motivational interviewing thoughts, that we're not trying to say, what are your motivations and your backgrounds and how do I understand that better? But you have an intimate way about allowing them to tell their own life stories. I mean, the time, I think all of us wish we had more time, with our individual patients who we're working with, but that's beautiful. Donna, off to you.
Yeah. So Joelle, we've talked in the past about some of what you see in regards to patients, families, caregivers, and even like the medication side of things too. So, and just some of our listeners might be going, okay, so where are they going with this? I thought this was the med list. But I think all of this background information is so important. And so I have a couple of questions for you in regards to this. I'm assuming that for someone who we have a lot of people living longer with Alzheimer's and other cognitive issues. I'm assuming there might be some issues with the caregivers going, like, what do you mean you want to take those meds away? Or maybe they're unpacking because of their own grief of caregiving and things like that. So we've had folks on who, caregiver advocates and et cetera. I'm just curious, your dynamics have to be so different for each individual you're speaking with and what you're trying to convey to help with the process. So whether it be adding on meds, reducing meds, what do you see? Like as this clinical chaplain, what are you seeing? Like, oh my gosh, look at all these meds. How do we help get the person off of some of these meds? How do we make them feel comfortable with meds that might need to be taken? Or what is going on there for you?
That's a lot. That's such a great question. Two big themes instantly like pop into my head. One is the aspirational medication that they don't want to let go of, like I think it's Namenda, some of the, you know what I mean? Because maybe they're going to, that one's a hard one to let go of, like that class of the dementia drugs.
The dementia,
and
type classes.
We have to do a lot of educating around why those really aren't, worth keeping at this point. And this is speaking from a hospice point of view, so I should qualify that. The other ones there takes some education about like, well, what if you stop their cholesterol med? Won't their cholesterol spike up? So there's a lot of education that has to happen around. Again, that's really not something that we're going to be too concerned about at this point. So it's like you're still trying to lead people sometimes to understand that this is the end. Do you know what I mean? That that the side effects and the things of these drugs are aren't worth it at this point. Like, let's go for quality as opposed to trying to stretch out the quantity, because you can be more intentional with your time. The other big thing I have, and that I see so often, is the fear of morphine as a good palliative drug. I see that all the time. Fears of addiction, fears of it's going to snow them and they're not going to be able to have any time, to talk. And those are valid fears. Especially the one about them making somebody too drowsy or incoherent. But if dosed well, it has the palliative piece, and the person can still interact well with the family. So those are two big themes that I see.
Wow.
So, go ahead, Kevin.
Oh yeah, you're good. I was just going to say something that we talked offline, and I wanted Joelle to mention it to the audience now that we're on together. You were saying previous, Joelle, and I'll let you use your own words, not mine. Where would people encounter a clinical chaplain, like through the life cycle most often? And then most important follow-up, where do you feel like we should be encountering clinical chaplains throughout the life cycle?
Well, I'm going to be, I'll put a little bit more definition around this. A board certified chaplain is where, and where somebody specializes sort of within that is sort of a newer phenomenon. But board certification is truly, that's when somebody's put in that extra effort in this field to go above and beyond. There's a few certifying bodies. There's 3 or 4 main ones. So if somebody has a BCC after their name, they've done that extra work.
Okay.
It is not a requirement to be BCC to be in hospice. You will usually see that really required in hospitals, that someone has to be board certified. Because what can happen is sometimes you have a lot of very good and wonderful people that do ministry in other parts of society that sometimes will do it as a part-time thing, or you have some great military chaplains that come out and their training is pretty rigorous too. I'm not as familiar with it, so I don't want to speak to it, but I know that they have a lot of training as well. And they make good, I think, transfers over into sort of public sector if they want to. Oftentimes they have their hands full with what they're doing already. So we're in all sorts of spaces besides hospice and hospital. A lot of times places that do addiction treatment will have some kind of spiritual care component.
Got it.
I had a few people in a couple of my CPE units that worked in addiction spaces or even mental health.
Okay.
Sure.
And that's where you would, you want to see more clinical training or more of that clinical pastoral education to sort of know that there's some enhanced skills there. And again, I want to be very clear that I am not saying that it's a requirement to be a good chaplain to go through it, but it's something that is like an extra step that one can take in my particular profession. But they have chaplains at airports. Airport chaplains, and pretty much some long-term tiered facilities, which I love that. First one I met down in Florida was a gentleman who, it was a place that had an independent living and assisted living, and then it has skilled.
Yeah.
They had spiritual care.
Wow. I think with that, Donna, I really love the idea, because we've talked to dietitians, nutritionists, exercise physiologists, and we're always hoping, it's a disservice to patients if we say, hey, you should exercise, or hey, you should eat right. Well, what's that mean? Where do I go with that? How do I find an expert to really guide me? And then other things that you and I have seen clinically isn't just end of life and saying, hey, what are your spiritual needs, right? What are your internal needs to be able to take these medications, as Joelle just mentioned? We also encounter that with other stages of life. Like, are you depressed? Should you take an antidepressant? What is the deprescribing of an antidepressant or an anti-anxiety medication like? What's withdrawal like? And how does that impact you spiritually? I think all of those things, there's really large missing gaps when it comes to what do medications actually put human beings through, and how could a chaplain be able to help you through some of those things for that mental and or spiritual fortitude components. But pass it back to you.
Yeah. So I definitely think, Joelle, that when you're talking about military chaplains, one of my uncles was a military chaplain, and so he was a priest. He was a chaplain in the Air Force, and he left and eventually became a community in working with people who with their mental health. And he was just incredible man with all the folks that he helped, and his spiritualness. Always very special to me. So when you mentioned that, I was like, oh, my uncle. um, but with that, we had spoken to about, we really think about, like Kevin was saying, the exercise, and to be healthy in that way, and get enough sleep, and all of these things, right, all throughout life for a good, healthy life. We don't necessarily talk a lot about good, healthy mental, spiritual health too, and all of that when we're talking about exercise and diet. So could you explain a little bit more about, I know that you had mentioned to me at one point about a good life leading to a good end of life, and or sometimes it's not that way, and how we might need to change that around. So if you're speaking to us and sharing, like you wanted to help people in the community, similar to like what I want to do is help people before hospice. I want to make certain that they're off medicines early on, preventatively. How would you preventatively share what we should be doing now for a good quality life to a good quality end of life?
Oh, wow. That's a lot, because you ask a question. You both do. I love the questions. There's a lot of sort of pragmatic stuff that I've seen over the years working with seniors. And I think you and I had this discussion. Wear the hearing aids. They help your balance. It doesn't make you look less cool. It makes you look smart, actually. You know what I mean? Use the walker. Use the compensatory strategies, because you're good. If you fall, that opens up a whole new, set of problems. But for spiritual health, unfortunately, in hospice, you see people come to the end of their life who might be no contact with people in their family, might have church hurt, might think they're being punished. So there's some theology that has gone with them that is disappointing. There's the family component is huge to me. My thing is always run it through the filter. Like, do you always have to be right? Do you always have to be right? Why? I see there's a trend right now of no contact, like kids with parents that, and these are parents that are like my age. And I can't stress enough how much good communication is so important to people's spiritual health, and getting help and saying that this is too much for me when you need to, as opposed to waiting until you're ready to snap and take it out, sort of in all facets, or hold it in, which I think can cause illness, quite frankly.
Sure.
And if there's a faith community that you feel comfortable in, lean in. Having community is so important. Knowing that you have people that care about you and will be there for you, to me is huge, which is why I do the community work that I do, because I think talking about things like grief, like the fact that we're impermanent, we've taken death and just put it away. We've hidden it. We put it into skilled facilities. We put it behind hospital doors. We don't lay people out in the parlor like we used to, so that kids could be around death and understand it and be talking about it and explore bigger themes. I don't know if it's always the best thing to not have that conversation with a kid. And of course, age appropriate discourse.
Mhm.
But we've made being like living forever like a goal. And I don't know if that's like a good goal.
Yeah. Like quality over quantity.
Yeah, and I 100% don't know if I answered your question. And my computer is not plugged in, and I have to do that, or we're gonna
Okay.
not be talking anymore. So
No worries.
The one thing that I love about that, Donna, that Joelle just kind of unpacked there was the hiding, of things that really matter. Ta-da, she's back. The hiding
blood going on my face here
is a really interesting thing, Joelle, that you just talked about of let's sweep it under the rug. Let's not talk about it. Let's make sure that the only time we talk about it is when it is so late into the game that we can barely have time to process it or even think about it, right? Until the individual is gone, the healing, the potential for healing is no longer there with an individual being present, right? And oftentimes I would probably say that we do that with life quite often. All the things that actually matter in life, we try to sweep it away because we got this one deadline at work, or we've got this other thing, or this meeting, or this appointment, or something else going on, that all that baggage that you talked about kind of accumulating, we try to avoid. Like, we try to avoid that conversation. Where in the healthcare paradigm do you feel like, Joelle, where do we insert that back? Like, how do we, like you mentioned, community, which I love, right? But we have such a detached society right now in lots of studies. We've talked about what is one of the leading causes of death. Today we talk about heart attack and diabetes and cancer, et cetera. A lot of prognosticators are saying one of the big indicators of disease moving forward, you mentioned it already. You talked about that baggage, is loneliness.
Yep.
Like, loneliness is something that a lot of folks should be worried about on the way we're developing society today. So when it comes to the role of the clinical chaplain, where do you see that level of reconnection? Instead of sweeping life away, instead of sweeping death away, that we actually address these things that are so meaningful? How do we reinsert that into not just clinical medicine, but back into society, leveraging the role of the clinical chaplain?
That's a great question. We need to prioritize human connection again. Just because we can do everything via distance, and there's great applications for that. What we're doing right now isn't something that we could have done before. And again, that's a great thing. But I know when I was a kid, I was like feral. Do you know what I mean? Like, I was out and I played out in the dirt and I did all kinds of stuff. And my kids now with the phone, I'm like, really, with the phone? You know what I mean? Like, see what your friends are doing. Go outside. So it's starting like really, really young.
Yeah.
And then when you have like the different generations, like each generation sort of has its thing. And then we've just become so bad at learning how to just be with each other. The polarized politics, we don't even know how to have a conversation anymore. And something struck me today. I was running a grief group for a retirement community in Worcester. And a little lady said, she was kind of recounting all of her losses.
Wow.
I was like, wow, that's a lot. And she said, yeah, but I smile because nobody wants to hear about it. And I was like, I would bet you if you talk about it, other people are going to want to hear what you have to say. And they're going to tell you their own story.
Yeah.
Because grief and loss is a club we will all be a member of.
Absolutely.
Nobody escapes that.
Yeah.
So finding commonalities across, we have so much more in common than we think. It's not hard for me to go into a group of complete strangers to start a group and just start asking some questions here and there. And one person will say something and I'll pull what they're saying and I will pull other people and start. Pretty soon everyone's like, yes. Because group therapy, the gold standard for, I think, grief and a lot of other things really is you're sharing your experience so other people can hear that and say, all right, I'm not going crazy. And this other person is going through the same experience I am. And that starts to create its own community. So I do caregiver support and I do grief support. And I'm wondering what else I can do. I'm always looking, my pistons are always firing here because I want people to be interacting with each other.
Right. So, Joelle, I know you do counseling for other people too, in regards to other losses. So, for example, it doesn't have to necessarily be a person. It could be that pet that somebody might have, whatever
Mm,
loss it is. Maybe it's a loss of your children being around and being an empty nester. Some people don't do well with that. Sometimes it's life changes of, and we were talking about this, even menopause and the changes
yep.
in life for women. And so some of these things, that's a loss for some people. And how do they work through that? And I loved talking to you about some of those things, and it was just like, wow, this is such an awesome idea. And I don't think everyone's comfortable with saying, "Oh, I'm gonna go see a counselor." I
Mm,
think if people can go and see a chaplain, a board certified chaplain on these types of things and know that that's available, that might be a better connection than thinking like, "Oh, I I'm not comfortable with a counselor per se, but I could get onto a more, a level with a chaplain, I think, instead." Do you see that as being maybe a fine line? Maybe it's just that little bit of difference where it's almost like brand versus generic. I only want to go with the brand. Not that um, but
that's
I'm
a
just
really good
wondering,
question.
is there a preference for some people? Do you win some people over, or some people like, no way am I going to speak with a chaplain, rather speak with a
That's a
counselor?
great.
How does that go?
That's a really good. Even just like that tail part is really good too, because um, again, getting back to the misconception about chaplains,
Mhm.
um, I don't usually pray at all with my private clients. Because oftentimes they're there to talk about some of those other losses, and like
Mhm.
from divorce to people that do have children that have gone no contact to um, some folks today were talking about when they had to give up their home and
Mm,
they had to downsize.
mm,
There's grief with that. The companion animal, it's huge. I mean, I know myself that my first dog, my golden retriever, it took me 2 years to get over her
Wow.
before I could even think about getting another dog. But
mm.
because we live in that society where you get 3 days off for bereavement, people will say, it's just a dog. Get another one. Do you know what I mean?
Mhm.
And I think that sort of easy fix doesn't work. So when I work with people one to one, I like to unpack everything and kind of encourage them that really the only way forward is through.
Mhm. Yeah,
You know what I mean? And to honor where they're at,
yeah,
and what they're feeling. And people want their stories to be heard. They
sure.
want their pain to be witnessed.
Do you find that after speaking and helping people through whatever grief, and we know that, people do go through depressions and at these times of loss, etc., and might need medications at that time. Do you continue with people, or have you heard from people saying, wow, this really helped me and I was able to then eventually be able to move forward and through, I guess through is what we're
Mhm.
saying instead of forward, being able to move through this and feel better and maybe feel that I might not need this particular medicine because I've been through the training, if you will, the exploration, and I'm healthy now. I don't
Mhm.
necessarily feel that I need the medicine, and try to, with their, healthcare providers, to wean off of some of these medicines.
That's a wonderful question because I think I've only had one client that was on medication, and I know enough about side effects and some of the things that she was experiencing for me to encourage her. You please call your psychiatrist and let him know that that's going on.
Mhm,
Um, I I think grief is a very normal reaction. So I am not somebody who encourages medicine for grief. Now there are complicated griefs that interfere with people's life and they cannot get out of bed. That's a
sure.
whole other conversation.
Mhm,
But for uncomplicated grief and loss, normalizing that yes, you are going to burst into tears sometimes. 6 months out, a year out, it happens. But if you're still functioning and able to do the other things and still find joy and laugh sometimes, I don't know if medicine is like the answer there. It's time, it's support, it's expressing yourself. These are things that I think are better. So I try to sort of walk them through that process, and sort of companion would be the word I would use rather than lead, because I walk beside. And that to me, like I said, and I always go back to this, people just want their stories heard and they want to be witnessed. So whereas I do think there is a place for antidepressants and such, if something were to be, there are some traumas that are hard to bear, and sometimes the medicine gets you through the crisis.
Sure.
But eventually you're going to have to do the talking. That has to be a component. And I think that sometimes is missing. You know what I mean? The medicine is there, but we're not getting to like the root. So, and like even circling back to addictions and things like that, are people being heard? And are we getting at the root of why they're self-medicating?
Yeah.
Wow. Yeah, I had one that's and I didn't prep, so forgive me, audience. I didn't prep Joelle for this question at all, but it just kind of really comes to me with what she was just saying is, especially with your in-depth study over a period of time of the science revolving around this process in life, what cultures have you seen, like Donna was saying, like we tend to medicate, right? In Western medicine, if there's a problem, there's a pill for it, right? And that's the way we approach it, which everybody knows that that's not the way Donna and I feel, and I feel like I say the exact same thing about Joelle. When it comes to other cultures that you've seen with the death and dying process in particular, since you have a real specialty in that space as a chaplain, what other cultures have gotten it right? Like, what have they done that we could learn from, that in your studies you went, man, there's some things from this culture and this culture that I really love the way they went about it, and I wish we could start including that or incorporating what we do.
Now, when you say cultures, can you be more specific?
Yeah. So for example, like within Native Americans, when we have someone that passes away, when we do our funeral process, it is different from what I've seen in Westernized society, especially with the gift giving and the way that we think about grief over that first year after someone has passed, and the things we don't do and the remembrance components that happen. But are there other cultures, ethnicities that you've seen, they have certain practices that they've leveraged around the death process and dying process that we could learn something from, and the reasons why you feel like we should learn something from those?
I have found that I see fewer folks from Hispanic communities on hospice.
Okay.
And I'm trying to think. I think I've only, for me, because I see a lot of people in nursing homes, and I'm in the suburbs too. So I think there are a lot of cultures. I've only met one gentleman who was a Muslim. And like I think some cultures try to keep people at home and care for them themselves.
Yeah.
And we are, the white Anglo sort of is very highly represented in the work that I do. And that gives me pause, because we aren't doing the multi-generational thing that I do see other cultures doing, who would rather keep their loved one at home and care for them. And I don't know how much gravitas I should put on that, but it does strike me sometimes that the numbers are quite skewed to white Anglo.
That's very interesting. No, thank you for the anecdote. I really appreciate that.
Yeah.
So, Joelle, I know that you mentioned that you really wanted to make certain that we really highlighted the need for the work in the community.
Mhm.
And so could you just highlight again, or even more so, the work in the community, and just kind of some ending thoughts of what you find really important with the work you do and and how do we make it more mainstream for people to feel like, oh, this is such a great idea for me to reach out to. We know about the dietitians, we know about the PT and the OTs and all these other clinical folks, but how do we educate more or share more on the community side of chaplaincy?
Well, looping back to people have a lot of misinformation about chaplains. People will actually even refuse me in hospice.
Oh, interesting.
So we try to sort of massage the way you're going to meet everybody on the team, and then you can decide who you want to continue. You know what I mean? So,
Mhm.
and sometimes I'll get, when I say that I'm a clinical chaplain, they'll say, but you're a woman. I am. They let us be that now. They let us do that. They let us vote too. No, I'm just kidding. And I think the huge thing is, I feel like I am in a position to educate, about the profession.
Mhm.
And what's interesting though is that, like, for my community work, I go into places and I just say, what's the need? Do you have like a lot of people grieving? Do you have a lot of caregivers that need support? Because
Mhm.
caregiving is very hard. It's very expensive. There's a lot, people think with hospice that we move into your house. We don't. There's a lot of spaces in there. And when I have my chaplain hat on, I have a caseload. When we're done here tonight, I have to chart because we had a bunch of admissions. So
Mhm.
um, there's a lot of time constraints. When I wear my death doula hat, I have a lot more time. I can be really present to families and to the community, which is the leg that I do a lot of my death education.
Mhm.
The chaplain piece, I like to educate about hospice and the benefits of hospice. But I like to create community spaces where people can come and talk about hard things. And I have a particular, I feel particularly called to support the LGBTQ plus community
Yeah.
because it's a very disenfranchised community. And I have seen people closeted at a time when they should be able to die authentically as
Mhm.
their whole self. And you can see I'm starting to get my hackles up
So
um, because
yeah,
I'm
rightfully so. Yeah.
very passionate about it. I had a grief
Agreed.
group from Florida that I took up with me, and we did it by Zoom because we couldn't find the right person to take it over from Sarasota, Florida. So I
Mhm.
took it over, and I learned so much about their experience, and it just broke my heart.
Yeah.
And I have
And
my own experiences in that community, and for me, it's if we can't let people die authentically, then
yeah.
we have a lot of work to
Mhm.
do.
I actually was at a program and I was a speaker at the program, but there was also um, a woman there who had transitioned, and she was saying how being older now, she's in her later 50s, and she's concerned that, how am I going to be cared for? And it is a big concern within that community,
Yeah.
and to be respected. And there's a lot of work that needs to be done in that area too. So, it's everyone counts. We're all humans, right? And we all need that space in order to, like you said, be authentic, and, get the care that we need too, and to be able to receive care. So I think that is such an important part. So there's so much more to explore here. My goodness, we could go on and on. I just love the education we got in regards to um, just clinical chaplain and just what you're doing. It's amazing. And I really hope that our listeners, and whether it be the caregivers or whether it be the providers, let's start thinking about what people's needs are beyond diet and exercise and good health, and being able to have a quality of life that leads to a quality end of life. So I can't thank you enough for sharing all of this with us, Joelle.
Thank you so much for having me.
Yeah, I really appreciate so many of the perspectives you leaned toward our direction there, Joelle. I think that the thing for the audience that I'm pulling away is really those aspects that were mentioned with what are we hiding, right, in our own lives and not unpacking and working through. And the huge benefits that you have seen and several of my colleagues inside the counseling world have told me about when it comes to groups and being heard, in general. And I feel like the referral process and the dynamics of dealing with disease and death and dying, it's something that the medical community needs to leverage more often, in our small communities, and really be able to talk about shared life experiences and some level of connection that can be found through those. And I think what a great service for a clinical chaplain to be able to be the conduit for is really to make those connections and bring those people together. So I think that's a really beautiful component. Any final notes or thoughts from you, Joelle, before we close out the show? And once again, thank you so much for your time.
Oh, well, again, thank you for having me. And I just invite people to consider, if we were able to unpack some of these things and be in community, I suspect we would consume less, we would feel less afraid, we would feel less afraid. And I think we would be able to find that we have so much more in common than we even know.
Amen to that. I can't agree more. Well, thank you all for joining us. Thank you, Joelle, for being here.
Kevin, just one more thing. And like I had said in our post, I'm loving what came through with conversations between pharmacists and a chaplain. And who knew what was going to come of this? I think it was fabulous. So thank you.
I love it. Great conversation. Well, we will talk to all of you guys next time. It's YouTube, LinkedIn, Facebook. Where else, Donna? Apple Podcasts, Spotify. I mean, goodness gracious. It's tough to keep those all straight. But if you're tuning in, thank you so much. We appreciate it. And we'll see you guys next time.
Sounds great.